Hi everyone, welcome back to our course. Today we are talking about oral health policy in the United States. And in our forest and tree metaphor, it's one of the clouds again in the sky. There have been so many clouds we've seen in the sky, and this is definitely an important one. And we're joined today by two experts from the Harvard School of Dental Medicine who are joining us to help you understand this better. Mary Tavares is the program director of the Advanced Graduate Education Program in Dental Public Health at the Harvard School of Dental Medicine. And Dr. Christine Reedy is a lecturer in oral health policy and epidemiology, also at the Harvard School of Dental Medicine.
Hello, my name is Dr. Mary Tavares. In this session, my colleague Dr. Christine Reedy and I will provide you with an overview of the issues in oral health policy in the United States today. About myself, I'm a dentist and I'm a board certified in dental public health. In addition to conducting research at the Forsyth Institute in Cambridge, Massachusetts, I'm also the director of a graduate program in dental public health at the Harvard School of Dental Medicine. What do we mean by oral health? How is it different from dental health? As you can see in these excerpts from the first ever Surgeon General's report on oral health, this is a concept that goes far beyond teeth to include the structures that comprise what they call the craniofacial complex. To quote the report, these are tissues whose functions we often take for granted, yet they represent the very essence of our humanity. They allow us to speak and smile, sigh and kiss, smell, taste, touch, chew and swallow, cry out in pain, and they convey a world of feelings and emotions through facial expressions. They also provide protection against microbial infection and environmental insults. The craniofacial complex is inextricably linked to the body in a myriad of ways. Keep this in mind as we progress through the following discussions of the oral health care structure and the delivery system in the United States today. Let's start with an overview of U.S. oral health policy. In this section, I will present the challenges facing the oral health care system today, a glimpse of its history, and a description of its structure. At some point, dentistry separated from medicine rather than becoming a subspecialty of medicine. This schism has been reinforced in all aspects of the oral health care system, from professional education to the way that oral health care is delivered and financed. The surgical model of care delivery has dominated dentistry with a strict fee-for-service system that assigns dollars to specific, mostly invasive procedures while minimally funding diagnosis, prevention, and health maintenance. Procedure-based care delivery has also had an impact on designated roles in the delivery of care. The separation of the oral cavity from the rest of the body and the ensuing characteristics that it has bestowed on oral health care has resulted in the second major challenge faced by the profession: access to care. Access is greatly affected by the financial and workforce models in oral care, as well as by health literacy levels among patients. A bit of history in terms of some milestones helps us to understand how we got here. Pierre Fauchard, a French physician, is considered to be the father of the discipline of dentistry. In 1723, he wrote The Surgeon Dentist, a treatise on teeth. A physician wrote the first description of how to care for teeth. A shift away from being part of the medical profession occurred in 1840 with the Baltimore College of Dental Surgery. This school was not originally part of a university system and was created to train what would be called dentists. A few years later, a professional advocacy organization, the American Dental Association, was established to support this profession. Other dental schools, however, were created as part of medical schools, Harvard being the first in 1867. Today, Harvard dental students still spend their first 2 years in the medical school. The discovery that fluoride could prevent tooth decay launched the field of dental public health that would widen its focus to prevention of oral disease and access to care. In the 1960s, when government began to get involved in financing health care, the dental profession stayed away. This was accepted because dentistry was not viewed as being part of medicine, and at that time, dental work was relatively inexpensive. The need for dental coverage seemed far less than for medical. Some of the consequences of the historic siloing of the dental profession were brought to light by the Surgeon General's report in 2000, citing the silent epidemic of oral diseases. The report pointed out the disparities in disease among the poor and vulnerable in our society. The Children's Health Insurance Plan, followed by the Affordable Care Act, have tried to improve oral health disparities for children. Dental care delivery falls into public and private systems. The public systems align themselves with government, as we shall soon see. Solo practice is the principal form of dental practice in the United States. Annual surveys taken by the ADA show a slow but steady shift from solo practice to group and employee practices over the past 12 years. It's notable that almost 90% of all private practices are located in metropolitan areas, with less than 1% in rural areas. Looking at the public side of oral health care, we start with the federal government, which, unlike medicine, has a fairly small role to play in financing, covering only specific vulnerable populations. The federal government's main role in oral health is in the research and regulatory arenas. The National Institute of Dental and Craniofacial Research at NIH supports basic and clinical research, as well as research training and career development programs. The Health Resources and Services Administration grants support programs and training of health professionals for underserved populations. Medicaid is the largest government payer of oral health services and is administered by the states, resulting in large variations of benefits between states and over periods of time. Dental services, particularly for adults, are very sensitive to the fluctuations of financial climates in each state. State governments also finance programs for special populations, and the rise in school-based programs has been the most significant development over the past 20 years. Additionally, through departments of public health and boards of registration, states also have a regulatory role in oral health care. Local municipalities play a role in programs for public benefit. This varies greatly by community depending on its resources and abilities to obtain grants. For example, the City of Cambridge, Massachusetts has an oral health division in its Department of Public Health and conducts annual surveillance of school children, while neighboring municipalities no longer have the resources for such a program. Community health centers, many of them federally funded, offer a source of health care for those who cannot afford it. 80% of these centers now offer dental services, and they have seen a precipitous rise in the number of patients seeking care. The Affordable Care Act offers additional financial support for these sites. Let's summarize the structure of oral health care by looking at its political landscape. In addition to the government stakeholders that we have discussed, there are many others. Organized dentistry is a key player. You will recall that the ADA was created right after the first dental school opened. Within the ADA, there are organizations representing all the recognized clinical specialties, as well as state and municipal dental societies. Hygienists and public health dentists also have a political voice. Insurance companies, advocacy groups, and the rise in corporate dental care delivery groups round out the stakeholders.